Okay, so the meeting is being recorded for the benefit of the students that are coming tonight. It is not going to be made available. You guys are not going to have a link to this recording. That is why we said it's not being recorded, because it is for our use, but it's not going to be given to you guys, okay? So we'll start with health promotion. Birth control is a big one. And I always take a crazy amount of time going over birth control. I don't know why, but I'm not gonna do that this time. I promised myself, all right? So you guys know that there are different methods of birth control. You have the natural family planning. We have the barrier methods. We have the hormonal methods. And then of course we have the surgical, transcervical sterilization and surgical methods. So let's talk a little bit about the family planning. Family planning includes abstinence, coitus interruptus, or the withdrawal method, the calendar rhythm, and the standard days methods, basal body temperature, cervical mucus ovulation detection method, and the 2-day method. All right, you guys can read that. I'm not going to talk to you about it in detail. What you need to know is that while they can be effective, they're not 100%. All right, the failure rates are considerable, and the only one that is 100%, it's abstinence. However, if you're abstinent 29 days out of the month and on one day you mess up, your chances are out the door. All right, so again, it works if you're using it. It's 100% if you truly are being abstinence, but not being practicing abstinence for 29 out of 30 days. That's not gonna work. They also do not protect you against STIs. Advantages is they are free, and outside of pregnancy and possible STIs, there are no side effects because there's no hormones involved, there's no medications, okay? But the compliance with those is not the best because it does require a lot of work. You also need to have a regular period. If you have an irregular period, a lot of these methods will not work for you. The barrier method, we have male condoms, female condoms, spermicides, diaphragm, cervical caps, and contraceptive sponge, right? So the barrier methods really don't have any hormones, which is good. So there's like no side effects when it comes to that. The male condoms, the advantage is that they're quite inexpensive and easy to use. The female condoms are a little bit more expensive, a little more complex to use. People complain that they are noisy during intercourse and that it may be a little bit bulky or complicated to use. Please note, you cannot use a male condom with a female condom at the same time. So keep that in mind. Spermicides. Spermicides are, can come in the form of suppository foams or creams or gels and films. However, there are some of them that contain nonoxynol 9 or N9, and this particular component can cause lesions, which means if you're doing the spermicide, okay, you may not get pregnant, but if you are developing lesions in the vagina, you increase your chances of acquiring HIV. So please note, this has to be inserted 15 minutes before intercourse, and it's only effective for about an hour. Now the diaphragm. The diaphragm is, you guys know what a diaphragm is, right? It's like a little dome-shaped cup, all right? It fits over the cervix. So as it covers the cervix, it doesn't allow the sperm to go in and to fertilize the egg. It can be used with or without spermicidal gel. And there are different sizes available. Please note, a diaphragm must be fitted by a provider. So this is not something that you can go to the pharmacy and buy. Okay, it has to be fitted by a provider. And if there's fluctuation in weight, if you gain 20% of your weight or you lose 20% of your weight, you need to be refitted. It's no longer effective. And then also it should be replaced every 2 years, or if you have some type of abdominal or pelvic surgery. And then after every pregnancy, because your body changes with every pregnancy. So if you had a baby, you can't go back to using the diaphragm that you were using before you had this baby. Please note that you have to teach patients that they have to wash their hands, they have to do hand hygiene, and that the diaphragm must must remain in place for up to 6 hours. Can be inserted, 6 hours before intercourse, and must stay in place 6 hours afterwards, minimum, and can remain in there up to 24 hours. Was that confusing? So you can apply it early. Let's say you're going to go on a date. You don't want to be putting your diaphragm, right there during your date. So you could do it before. You could do it up to 6 hours before you think you're going to have, coitus. And you must leave it in place for at least 6 hours. 6 hours. And no more than 24. No more than 24 hours. Keep that in mind. It should be washed with mild soap and warm water after each use. It's very easy to insert. Again, this does not protect you against STIs because it is only preventing the sperm from going in through the cervix to fertilize the egg. It is not recommended in clients who have TSS, toxic shock syndrome. Okay. And it increases your risk of acquiring TSS. And then, of course, you have to tell the patients if you have fever, if you have watery diarrhea, macular rash, aches, that could be indicative of toxic shock syndrome. Some people can have allergic reactions and develop UTIs. The cervical cap is quite similar to a diaphragm. And same thing, it could be inserted 6 hours before. And it has to be left in there for at least 6 hours post intercourse, but it cannot remain there more than 48 hours. 48 hours. The disadvantages are the same thing: possible risk of toxic shock syndrome, allergic reaction, etc. Let me see. The contraceptive sponge. This is a concave shaped little sponge that has spermicide, and it fits over the cervix. All right, you do not have to be fitted by a provider with a contraceptive sponge. It is one size fits all. You just wet it before you insert it, and then it should be left in place for 6 hours after intercourse, and it provides protection for up to 24 hours. Again, none of these things protect you against STIs. The hormonal methods, we know we have combined oral contraceptives. We have the progestin only or mini pill. The mini pill have less side effects than the combined contraceptives. However, both of them have risk factors. All right, both of them. There are some contraindications, for example, with a combined contraceptives. If you have a history of thromboembolic disorders, a stroke, anything cardiovascular, gallbladder disease, cirrhosis, or liver tumors. And if you have a headache with neurological findings, with focal neurological findings, uncontrolled hypertension, diabetes, breast or estrogen-related cancers, you should not be on this pill. It is also contraindicated in women who are 35 years of age and smokers, because it increases your chances of having, a DVT or a stroke or anything like that. Oral contraceptiveness decreases when you take, it affects liver enzymes, all right? When you take some antifungal medications and some antibiotics, the effectiveness may be decreased. So make sure that you're aware of that and that your clients know that. The progestin pill only, same thing. Make sure that you guys go back and review the side effects. Are very similar. None of these hormonal methods, guys, protect you against STIs. Emergency oral contraceptive. A lot of us know this is the morning after pill. Please note the pill has to be taken within 72 hours of coitus. So if you had sex 5 days ago, don't bother taking the morning pill, because the morning after pill, because it's not going to work. If implantation has already occurred, it will not terminate the pregnancy. Okay. So if you're already pregnant, don't bother, because it's not going to resolve it. However, it is also recommended that you take an antiemetic when you purchase this, because it is known to cause a lot of nausea and heavier than normal menstrual bleeding. It can also cause cramping, headache, okay? This is not to be used for long-term contraception. This is like, whoops, what happened? And you do it once. This is not something you want to be taking constantly. Oh, it happened today, it happened tomorrow, it happened then. You're going to be taking one of these, you know, every other week or every week. Nope, that's not how it works. Make sure that you understand that. The advantage is that you can just walk in. You don't even need a prescription. Anybody can get it at a pharmacy. We have the transdermal contraceptive patch. The advantage of this is that it avoids the liver metabolism, okay, because it's not being absorbed through the GI tract. It's transdermally. It does have the same adverse effects as oral contraceptives. Again, risk of DVT. Let's see. Oh, very important with the patches. It's that if your client weighs more than 198 pounds, it's not going to be effective. All right. So you have to choose an alternative method of contraceptive if you are more than 198 pounds. The injectables, the medroxyprogesterone, all right? These are the injections that you get every like 11 to 13 weeks, okay? And please note, very important with patients doing these injectables is that they should maintain an adequate intake of calcium and do weight-bearing exercise because it is known to cause or to lead to osteoporosis. Again, this is also contraindicated in patients who have a history of breast cancer, if they have cardiovascular disease or abnormal liver issues, whether it's tumors or liver function, and if they have unexplained vaginal bleeding. Then you have the vaginal ring. I think we're familiar with that one, okay? Some people say that it is uncomfortable. The advantage is it doesn't have to be fitted. It doesn't protect you though against STIs. And like I said, the biggest thing is that some people say that they can, that it causes discomfort during intercourse. And the ring can be removed for up to 3 hours without compromising the effectiveness because it does have hormones. It's less hormones because it becomes available. The absorption is easier through the vaginal membranes, mucous membranes. So it requires less hormones, but it still has hormones. So you could take it out for 3 hours and you'll still be covered. Implantable progestin. That's I think one of them it's Nexplanon, but there's multiple ones. It's a little rod that goes in your arm. And this basically, you have to tell the patient to avoid trauma on that side of the arm. The contraception is good for 3 years. So you put in that rod and you know that you're covered for 3 years. And disadvantages, again, doesn't protect against STIs, none of these hormonal ones. And then please note that a lot of people develop unpredictable menstruation. So you don't have a cycle like you normally would. It just comes and goes whenever. People experience mood changes, acne, sometimes depression, and it also affects the bone density and causes weight gain. These are with the implantable progestins, all right? IUDs are a good alternative, particularly the copper T, if you have patients that are sensitive to hormones, because the copper T does not have any hormones, so you would recommend that. By the way, a diaphragm is probably one of the best methods for patients who are in monogamous relationships that are diabetic, okay? Because you don't have hormones, you don't have anything that can puncture, any part of you, so it is ideal for those patients. Then we have what we call transcervical sterilization. They are these little coils that get inserted into the fallopian tubes. Okay, this can be done at your OBGYN's office. And when the coils go in, what happens is 3 months later, it'll develop scar tissue around these coils. And with that scar tissue, it basically blocks the entry of any sperm. But you do have to wait. During those 3 months, you have to use alternative methods of contraception. Transcervical sterilization is not reversible. And then we have surgical methods, which is the bilateral tubal ligation or partial bilateral salpingectomy. Same thing. This is when they cut your tubes or they tie your tubes. And then we have the male sterilization, which is the vasectomy. The vasectomy is allegedly reversible, but it's not really, the reversals many times are not successful. So immunizations, I'm not going to go over everything with immunizations, but I want you guys to know that when it comes to immunization, it's important that women do get immunizations for whooping cough or the Tdap and influenza. All right. And we usually check for titers for like their hepatitis and rubella. However, please note with rubella, okay, with rubella, if your patient, if you do your patient's rubella titers and it comes back negative, you are not to give your patient a rubella vaccine. Why? Because rubella, the rubella virus crosses the placenta, okay? And it can cause fetal consequences. You can have a miscarriage, you can have fetal anomalies and even death. Keep that in mind, okay? Rubella is part of what we call the torch infection. The rubella, also known as the German measles, can be contracted through children who have not been vaccinated. Okay, so we tell women that if they are, you know, they're not going to get away from all kids and not be around any children, because most children are vaccinated. But if they see that there's a kid who has a rash, you know, kind of stay away from them. Rubella, most patients, the signs and symptoms will be joint and muscle pain, rash, and a fever. It is important that if they're pregnant, we do not give them the immunization during pregnancy. However, most clients in the postpartum period will get a rubella vaccine before they go home, okay? And very important, once the vaccine is received postpartum, please, you have to educate your patients and tell them that they are not to conceive or to get pregnant for at least 4 weeks, a month. And I don't know if you guys have your physical book or if you guys use the ebook. The physical ATI book that I have says 3 months after receiving the vaccine that they should wait before they, you know, conceive again. But the latest and greatest is 4 weeks, right? So after they receive the vaccine, they should not be getting pregnant for at least 4 weeks. Ideally, we want to teach our patients to minimum wait 18 months, right, before they get pregnant. So keep that in mind. And I'm not going to say much more about immunizations. Postpartum infections, okay? Postpartum infections, there's a whole bunch of them. Endometritis, mastitis, wound infections, a lot of things, you know, that can happen. So what are we going to talk about? We want to talk about when somebody has chorioamnionitis, they have the highest chance, you know, they have a high chance of getting endometritis, which is an infection of the endometrium, right? And it's the most frequently occurring puerperal infection. It usually occurs on the 2nd to 5th day, and patients will find that they have uterine tenderness. It's not your normal pain from the uterus that's contracting or from the nurse, you know, vigorously massaging your fundus. It generally occurs because of the infection from chorioamnionitis. Maybe they had prolonged rupture of membranes. Maybe, you know, maybe they had GBS and poorly treated, or maybe they have allergies to penicillin and the medication that they gave didn't work. They are more likely to develop these infections, okay? The endometritis, they'll have pelvic pain, they can get chills, fatigue, loss of appetite, etc. Excuse me. Yeah, so those are some of the risk factors for these types of infections. Common discomforts of pregnancy, and I'm focusing on a couple of them that we, you know, again, I can't go over the entire ATI book, but I do want you guys to be aware of this. Common discomforts, all right? What are we talking about? Nausea and vomiting. I'm sure you guys know nausea and vomiting occurs as a result of, at least in the first trimester, increased HCG levels. Your HCG levels go up, 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 up until you're about 12 weeks gestation. And then the placenta kind of takes over, HCG levels start to drop. This doesn't happen to all women. Some women develop what we call hyperemesis gravidarum, or they have nausea and vomiting. Maybe it's not hyperemesis in the sense that they have to be like, that they have electrolyte imbalance or anything like that, but they vomit and they have nausea constantly. So what are we going to do? Right? It's important that the client eat, dry toast or crackers in the morning before they get out of bed. So these are the patients that have to sleep with little like crackers next to their nightstand. And before, when they open their eyes, before they get up, before they brush their teeth, before they do anything, they need to eat a couple of crackers, wait a little bit. And that usually helps to keep the nausea and the vomiting at bay for the day. So it is important that they consume dry toast or crackers. You're not going to have them have dairy, oh, have a yogurt before you rise. That's not going to help. Instruct the client to avoid having an empty stomach. Okay, because what happens is when the stomach becomes empty, they get nauseous and they start vomiting, and then they can't consume anything. So you want them to have multiple small meals throughout the day, right? They should avoid spicy, greasy, or gas-forming foods. And then the other thing is that, let's say you want them to have 6 small meals a day. If they had a small breakfast, don't have them have their breakfast and then drink something at the same time. Tell them, no, when you eat, give yourself about an hour, and then you do your drinking. So do your drinking in between those meals. So multiple small meals, avoiding spicy, greasy foods, and then make sure that they drink not with their food. It has to be in between. Because think about it, if you eat a small little meal and then you drink a glass of water, everything in your stomach is going to expand. The chances of you vomiting then go up. So make sure that we discuss that. There are other common discomforts of pregnancy. We know that women, the breasts start growing in preparation for the milk that's coming in. Estrogen levels are going higher. So your breasts are growing, they develop tenderness. Have them wear a supportive bra. Urinary frequency is another discomfort of pregnancy that we must monitor. Why? Because a lot of women don't drink enough fluids, and they can go from having just, oh, I'm urinating a lot, it's because I'm pregnant, to then when they develop a UTI. So we need to keep an eye on that. We need to make sure that patients are well hydrated. But please note, urinary frequency is quite common in the first and in the third trimester, not the second trimester. We still, when it comes to the urinary system, we always want to make sure that we're assessing for signs and symptoms of an infection, because we know that a UTI can ultimately lead to more complications, preterm labor, etc. Teach your client to empty their bladder frequently, okay? And then they should decrease their fluid intake before bedtime so that they can get some rest. You also want to teach your patients while they're pregnant to start doing Kegel exercises. It's going to benefit them in the long run. Okay, it's going to reduce stress and incontinence as well. Again, going back to the UTI, keep an eye on that, because again, it can cause further complications. Encourage your patients to avoid bubble baths, to wear cotton underpants, and avoid tight-fitting pants. And then, of course, you want to make sure that they're drinking plenty of fluids. Fatigue, we know it's normal, also in the first and third trimester. Heartburn, also very normal, second and third trimester, due to the increased progesterone levels. All right. Make sure that they check with their provider prior to utilizing any over-the-counter antacids, okay? The one that they usually recommend for pregnant women is Tums. I think we all know that. Constipation can also occur, and have them increase, the fiber in their diet, roughage, a lot of lettuce, a lot of greens. Backache. How do we relieve backaches? Pelvic tilts. Okay, if you don't know what that is, it's almost like if you're doing a sit-up, okay, and you're bringing your pelvis upward, like you want to touch your belly button with your pelvis, okay? And that usually helps to relieve back pain. Very important. Estimated due date. They ask this question in every ATI. I know that. I don't know what the question is, but I know that they're asking sometimes multiple questions on estimated due date. This is what we call Nagel's rule. All right, so how are we gonna deal with Nagel's rule? With Nagel's rule, if I tell you, first of all, you need to ask your patient, when was the first day of your last menstrual period? Let's say your patient tells you it was April 1st. How are you gonna find out that patient's estimated due date. We're going to apply Nagel's rule. How are we going to do that? You are going to subtract 3 from the month. Sorry. You're going to subtract 3 from the month. So remember, April is 4. If you subtract 3, you're left with 1. So now we're in January. You're going to add 7 days to the day. So if it was April 1st, 1 plus 7 is 8. So now I'm January 8th. And then you add 1 to the year. So if it was April 1st, 2021, that patient's due date would be January 8th, 2022. So you subtract 3, add 7, and add 1. Now, tricky thing about adding 1 to the year. You only add that to the year if, pay attention to this, if the first day of the last menstrual cycle was after March 24th. So if the first day of her last menstrual cycle was March 25th, you're going to be adding a 1 to that year. If the last day of her menstrual period, the first day of her last menstrual period was February 10th, you're not going to add a 1. Why? A pregnancy is only 9 months. In February, you still have way more than 9 months before the year ends. Okay, so your cutoff is March 24th. Students get confused with that all the time. And they're like, do I add a year? Do they not add a year? Just visualize a calendar. Okay, and if they give you February or those months that, you know, sometimes can have 28 days, 29 days, or 30, 31 days, make sure that you take that into account. If it's this month, you know, that it started with, if it's the ending month, make sure that you take those things into account. So an example with the, let's say my patient tells me the first day of my last menstrual period was March 24th, which is right there, the cusp, right? March 24th, March is month 3. If I subtract 3 from March, I'm technically left from 0, right? 3 minus 3 is 0, except we don't have 0. What we have, the number that comes before the 1 happens to be 12 because we're looking at a calendar. So my due date is not going to be, you know, 0. It's going to be 12. And if it's March 24th, I'm going to add 7 days to that. And it's actually going to be December 31st of the same year. So if my due date is, if the first period of the first day of my last menstrual period was March 24th, 2021, my due date according to Nagel's rule would be December 31st, 2021. That's why I tell you that it's your cutoff. If my due date, the first day of my last menstrual period was March 25th, then my due date is no longer that same year. So I have to add 1 year. It's actually January 1st. Okay. So just so that you guys have an idea, please review that. Make sure that you know how to do that. Now let's talk about mastitis versus engorgement. All right. What do we know about mastitis? Mastitis is an infection. It has to be treated with antibiotics. Therefore, the patient has to know that they must notify their physician. Some people think, oh, it's going to go away. No, it's not going to go away. You need antibiotics. So it's important. Don't assume your patients will know or that your patients will make the right decision, because they don't. Number one, you may continue breastfeeding even if you have mastitis. However, you do need to notify your physician. Your patient is going to develop flu-like symptoms. They need to report it as soon as possible, and they will be prescribed antibiotics. Please note, mastitis usually occurs unilaterally. Can you have mastitis on both breasts at the same time? Of course, anything is possible, all right, but it's highly unlikely. So it's generally unilateral. It happens from cracked nipples, the baby latches on, bacteria gets in, so on and so forth. They do require medication. Engorgement, on the other hand, it happens, excuse me, it happens usually as a result of a mom who's maybe not latching on the baby as often as they should, a mom who maybe is not pumping as often as they should, or maybe the baby's not latching on properly and not sucking enough. So we need to make sure that we educate them on the proper latching technique. Remember, colostrum is produced from the time you're 4 months gestation all the way until, like, you know, after you have the baby. And 2 to 3 days after that, the milk starts coming in. Milk is produced 3 to 5 days after the delivery of the newborn. Prior to that, we only have colostrum, okay? Now,
I have a quick question.
yes.
I know it's unlikely, but if they do have bilateral mastitis, do they still breastfeed? Is that allowed or no?
Absolutely.
Okay.
You can actually put the baby on with, I mean, if you can tolerate the pain, yes, you can still breastfeed. And chances are the doctors will give you antibiotics that are okay, you know, for you to take while lactating. Okay. Now with engorgement, it basically happens from an result of lymphatic circulation, milk production, temporary vein congestion. Okay, the breasts get tight, really tender, they're very painful, and they are like hard, okay, like little rocks. If your patient, this is important, if your patient is breastfeeding, you need to tell them that the chances of developing mastitis will decrease the more, you know, the more often they put the baby to the breast, because they're going to be sucking the milk out so it doesn't get congested. So you want to encourage them to do that. You want to tell them to put warm compresses over the breast so that it makes them softer and easier for the baby to latch on. Okay. And they should definitely be washing their breast. Now, if your patient is not going to breastfeed and they develop engorgement, you want to tell them it's okay, this too shall pass, to make sure that they wear supportive bras, okay, or breast binders. And they should put ice packs over their breast or cold cabbage leaves. I know it sounds weird, but usually you get a cabbage, put it in the refrigerator, you peel a cabbage leaf and you put it over the breast underneath your very supportive bra, AKA breast binder, and 0 nipple stimulation. Because if you're stimulating the nipple, guess what's gonna happen? Milk is gonna come in and the engorgement is never gonna go away. So it's important that we teach our patients about that. Oxytocin. Let's see, what do we want to talk about oxytocin? You guys know why we use oxytocin. We use oxytocin to augment labor, okay? We use it sometimes to induce labor, and we use it in the postpartum setting as a uterotonic to help with hemorrhaging, okay? Let me just see something really quick. Okay, so when we're utilizing it during the labor process, why do we use oxytocin? The ultimate goal of utilizing oxytocin is to develop a labor pattern. What is a labor pattern? Contractions that occur every 2 to 3 minutes, you know, those are ideal. We want contractions that that last 45 to 60 seconds at least. They could be a little bit longer. It can actually be 80 to 90 seconds. And the intensity has to be strong to palpation. So when you palpate your patient's abdomen, you have to feel like, oh, wow, this contraction is strong, okay? And then, of course, ultimately, what we expect from the use of oxytocin is that the client is dilating 1 centimeter per hour. Very important. While you have your patient on oxytocin, we want to make sure that our fetal heart rate remains within those parameters of 110 to 160, and that we prevent tachysystole. What is tachysystole? Tachysystole is more than 5 contractions in a 10-minute period. It also means that we have contractions that are longer than 90 seconds. Okay. When would we discontinue it? When this starts happening, we want to discontinue oxytocin. If your baby becomes compromised because of tachysystole, you know, or if you see that maybe she's contracting every 2 minutes, but the baby's not doing well with each contraction, you have, let's say, late decelerations, and we're going to talk about those later, then absolutely, you want to make sure that you discontinue oxytocin. So if uterine tachysystole, we want to discontinue it. So if the contractions are tetanic in nature, what does that mean? They're lasting 2 minutes. Okay, you try to hold your breath for 2 minutes. This is kind of what's happening to the baby. When the uterus contracts, vessels constrict, okay? Uterus contracts, vessels constrict, your baby's like, okay, you're strangling him. So we don't want tetanic contractions. We need to allow the uterus to rest and the baby to recover from each contraction. If there is no relaxation between contractions, let's say this is your uterus and it contracts really, really, really tight. And then when it relaxes, quote unquote, it doesn't go back to where it was. It only comes back to like here. So it's doing this. So it never goes back to that complete resting state. We don't want that. You are compromising, you're stressing your baby out. And in those cases, we would definitely discontinue oxytocin. Please remember, guys, oxytocin is a high alert medication and must be ran through a pump. What are we going to do if we have a non-reassuring fetal heart rate? Okay, number one, we are going to make sure that we stop the oxytocin, all right? We want to put the patient sideline position. Why do we do that? We put them on sideline position because when you put them on their side, you increase placental perfusion. The blood, you're not, compressing the inferior vena cava. The blood from mommy is able to flow easier into the placenta, through the placenta to the baby. And you want to administer oxygen. You want to increase the IV fluid administration. Now, this is a big one. When you have a patient on oxytocin, she's not only receiving oxytocin. You have one bag probably of lactated ringers and one bag of oxytocin. When you are increasing, when you're bolusing them, make sure that you have the right line, that you are bolusing the maintenance fluid and not your oxytocin. I don't know if Dr. Perez was, I don't think she was at that hospital anymore, because her and I at some point, we worked at the same hospital, not at the same time, we worked at the same hospital, and there was a nurse, many, many years of experience. Okay, she went, a patient came in contracting, she went to bolus her, grabbed a bag from the Pyxis, failed to scan the bag before she administered it to the patient. And because, nurses love to find shortcuts. And let's just say she bolused her with oxytocin. The woman became, super tachysystolic. The baby was compromised. They run to the back to do a cesarean section. And while they're running with a stretcher to the back to do a C-section, the anesthesiologist notices that what's infusing, that what's bolusing was not lactated ringers or D5LR, it was oxytocin. So she was very lucky that she was able to keep her job. However, I'm sorry that she was able to keep her license. However, she was not able to keep her job. So make sure that you guys are cautious. If you follow, the protocol, the policies, those things are in place for your safety and for your patient's safety. Pain management. This is a fun one. Please note, guys, they love to ask about non-pharmacological methods of pain management. There are different sources of pain, and you guys can read it in chapter 12 of your ATI book. In the first stage, you usually have internal visceral pain that's spelled as back pain and leg pain. The first stage, remember what the first stage is, guys. It is from the onset of labor, when they go in that latent phase, you have the active phase and then transitioning phase. All of that is in the first stage. When they are complete, you transition to the second stage. Once the baby's out, then you go to the third stage, etc. But anyway, in the first stage, the cause for pain is visceral pain, dilation and effacement of the cervix, distension of the lower segment of the uterus, and then contractions of the uterus. So all of these things cause pain for your patient. In the second stage, you have somatic pain that occurs with fetal descent and expulsion. So as the baby's coming into the birth canal, guess what's happened to the pelvis and everything else? Everything's kind of opening, and yes, that is very painful. So make sure that you read that. Depending on the stage and the level of pain, we have different methods of pain management. We're going to first talk about the non-pharmacological pain management. First of all, you guys need to be aware or familiar with the gate control theory of pain. So the gate control theory of pain says that the brain only allows a limited number of sensations to travel at any given time, okay? So what do we do to decrease pain? If me doing this hurts, right? But then when I do this, it gives me a different sensation. There are two different sensations trying to get to my brain at this, competing to get to my brain at the same time. So we do things like cognitive strategies, or we do things like cutaneous stimulation. One of the big ones that really works with the whole idea of gate control theory of pain is effleurage. Effleurage is when they rub in circular motions around the abdomen. Whenever the patient feels that a contraction is coming on, they start rubbing with the tips of their fingers, or not them, or their significant other, whoever. We do effleurage, and that kind of confuses your brain. Have you ever noticed, just so that you remember what I'm talking about, when you go to the dentist, when they're injecting you that anesthesia, I don't know if you guys have ever had that done to you. Good dentists that know how to put anesthesia, you know what they do? And this looks funny, I'm sorry. They go like this. They start shaking your thing, right? They go like
They
this.
kind of wiggle that part that's going to be injected. So it kind of takes your focus off of.
Exactly, Maisha. There you go. That is the gate control theory of pain that is being implemented. When I give injections, I do that. You know, I'll pinch. If it's like an IM, an intramuscular injection, I will pinch. And then with this finger, I'm usually like touching their skin. And between the pinch and me doing this, they never feel the needle. Now, when the medication is going in, if it's like a vitamin B complex, it hurts. But they don't even, most patients will say, oh my God, I didn't even feel, did you inject? If the medication is not painful, they don't even feel it because it distracts your brain. So this is actually, you know, it works, I promise you. So anyway.
Does that also work for blood admin?
For what?
For blood admin, does that also work?
What do you mean? Any kind of pain? If somebody
well,
has,
like if you're taking blood out, does that work? If you do like the wiggle, do they not notice the needle going?
it doesn't even have to be a wiggle. It's the sensation of anything else. You can even have your patient with their own hand touch their thigh, another area of their body. It's the sensations that are going to your brain at the same time. So yes, it really works for everything. So anyway, even though it's a theory, I can tell you that I put it into practice and it works. And I know when I go to my dentist and they do that wiggle thing, I don't even feel the needle. So it works. I don't know if it works on everybody. It works on me and it works on my patients. So anyway, so cognitive strategies that are non-pharmacological methods. It's basically when you have a patient who knows what they're expecting. Like I'm here, I'm an educator. I love teaching, but even as a bedside nurse, I always told my patients, listen, I'm an educator by nature. That is my thing. If you have any questions, ask me. And anything that I was doing to my patients, I made sure that I was explaining it. Look, I'm going to do this, I'm going to do that. And even before I started doing it, when they first came in, I would let them know what to expect during the entire labor process, because knowledge decreases your anxiety. So patients who have taken childbirth education classes, Lamaze classes, you know, people who have a doula that has explained everything to them, they tend to be less anxious, okay? When your anxiety levels drop, your pain level also drops. So these are what we call cognitive strategies. It's the power of knowing. Another cognitive strategy too is hypnosis, okay? So just make sure that you understand that. Then we have sensory stimulation, where it's your other senses, visual, imagery, guided imagery. Aromatherapy is a big one. Like I know Dr. Perez loves this too, but like I live with my little diffuser that I could just pick up whenever and smell it. It makes me happy. This particular scent that I have here makes me happy. I love smelling that. But anyway, aromatherapy during labor works. If you want your patient to calm down, you have them smell lavender. If you want, and this is what doulas do, okay? If you want them to, if they're like really tired and they don't want to push anymore, give them some citrus stuff, okay? And mint that wakes them up, and they get energized with all of this. So all of these sensory stimulation strategies work. Music, oh, that's the best, to put like their jam, and they're like, I got this, like your workout music. I remember many moons ago, I used to CrossFit, And I always remember that when I would work out, they used to put this song. Oh my God, it's Rihanna. Yellow Diamonds from Rihanna. Was it Yellow Diamonds? I don't remember. One of Rihanna's songs. And every time I hear that song, like I'm conditioned. I tell my husband, oh my God, I want to like drop and start doing push-ups or doing something. So music works wonders for patients when they're in labor. I'm sorry?
Shine bright like a diamond.
No, it's not that one. No, it's the one that says, we fell in love in a home, something like that. It's not Shine Bright Like a Diamond. Anywho, I don't know anything, nor do I know how to sing, okay, guys? And you just made me sing. Anyway, my point is music is fantastic for this, okay? Breathing, using focal points, dimming the lights to relax them, especially if you have a patient who is anxious, etc. Then the cutaneous stimulation, effleurage being one of the ones that we talked about. Walking, if your patient does not have an epidural, encourage them to ambulate in the room, you know? Some facilities have the cordless fetal monitors. I think it's called MOA, I forgot what it's called. Anyway, there are some that are wireless, so they can actually ambulate the whole unit and you never skip a beat. They're still on your monitor, you can still see them. Rocking, okay, it helps a lot of women. It also helps with positioning the baby and getting the baby where it needs to be. Effleurage, which is what we just talked about. And then very important, sacral counter pressure. Pay attention to that. Sacral counter pressure. It's consistent pressure that is applied by the support person, the significant other, the mother, whoever in the world, you know, whoever's there, the doula, with the heel of the hand or fist, this part, all right, against the client's sacral area to counteract the lower back pain. So when your patient is getting a contraction, you know, like we picture a woman in labor and we think she's laying in bed. She's not laying in bed, okay? She could be on her knees, dangling from the top of the bed that has been elevated into semi-Fowlers or high Fowlers. She could be on all fours. She could be, you see this little picture that I have here, a woman sitting on a medicine ball. So if your patient is like that and she's sitting down or she's on her forelegs, however she may be, you put pressure in that sacral part with this part of your fist or with this, whatever is comfortable for you. And she, when she has the contraction, she pushes against that pressure and you push towards them. So it's like this, you know, going against each other. And that helps with the pain of the contraction. Then of course we have heat and cold, which helps. Hydrotherapy, if you work in a, you know, one of these nice hospitals where they have the whirlpool, or sometimes you could just let them go in the shower and take like a, you know, quick shower, and it helps to manage the pain. Acupressure, very important. Remember when you guys reviewed the 5 Ps, which is the passenger, the passageway, the powers, the psyche, which is their mental, you know, predisposition or disposition to be successful. And then the last P is position, right? This is very important, being able to shift from one side to the other. It helps the baby to kind of wiggle, you know, their way down into the pelvis, into the birth canal, but it also helps mom with pain management. So make sure that you are familiarized with that. Now, the other pharmacological pain management, there's a whole bunch. We have sedatives. Sedatives are usually given very, very, very early on in labor, and it is to calm the patient down if they have a lot of anxiety. It doesn't take away the pain. We have the opioids, okay? Opioids can be used. However, please note they cross the placenta and they are generally given with antiemetics because they will make you nauseous, all right? So they usually give ondansetron and what's the other one? Anyway, with some type of antiemetic. And anytime you are given opioids, you need to make sure that you have the antidote, which is naloxone or Narcan, okay? Naloxone is the opioid agonist and should be readily available because let's say somebody becomes respiratory depressed as a result of the opioid that you gave. We also don't like to give these if you think that they're gonna deliver within the next 12 to 24 hours or 12 hours really, because since it crosses the placenta, guess what? The same way mom feels, the baby feels. So if mom has respiratory depression and is sleeping, guess what's happening to your baby? same thing, baby sleepy, when they're born, if you just gave it, 2 hours before the baby was born, when the baby's born, they're going to have to work them. They're going to have to maybe sometimes give them a little bit of Narcan. Then we have, of course, epidurals and spinal regional anesthesia. Please note, with epidurals, one of the biggest things is that it can cause maternal hypotension, fetal bradycardia. Your patient is not going to feel like when they have to void, they're not going to have that sensation. So you need to make sure that you are offering a bedpan frequently, or that you do not a straight cath, that you put in an indwelling catheter, a Foley, so that their bladder is not full, and you don't have to be constantly thinking about, oh my God, I'm going to put a bedpan, or that you forget. An epidural basically consists of a local anesthetic, bupivacaine, along with analgesic morphine or fentanyl, and it is injected into the epidural space at the 4th or 5th vertebrae. Okay. So usually we don't want to give an epidural block until your patient is about 3 to 4 centimeters. Your ATI book says 4 centimeters. In the real world, we give it whenever the patient wants it. Some doctors say if she's 1 centimeter and she wants an epidural, give it to her. Allegedly, there is no evidence that says that it delays labor, but I think there's new studies that are coming out saying the opposite. The ATI book says that they recommend that it be given when the client is at least 4 centimeters dilated, so that it doesn't hinder the labor process. It is suitable for all stages of labor, all right? Even to do an epidural repair or laceration repair, it numbs them so that the doctor is able to do what they have to do without the patient feeling any pain. Please note, nursing actions whenever administering an epidural, you need to make sure that your client is well hydrated, so that you decrease the chances of your patient developing hypotension, all right? So administer a bolus IV to help offset the maternal hypotension. Monitor the blood pressure and the pulse, all right, for hypotension and respiratory depression, and also decrease O2 sat. Be prepared to administer an IV vasopressor such as ephedrine. Usually anesthesia has, whenever they give an epidural, they have ready to go a little syringe with ephedrine, because they know that patients can bottom out, that they can pass out, and ephedrine just usually gets their heart going and brings them back up. Okay. Do not allow the client to ambulate unassisted. Most patients, once they get an epidural, they're not coming out of bed. All right, they're staying in there because it's a hazard. They will fall. Their legs are weak. Okay, so you need to make sure that you don't allow them to ambulate. Yes, Julia? Somebody say something?
Sorry.
Okay. Again, make sure that you're assessing the bladder. If they don't have an indwelling Foley catheter, make sure you're assessing the bladder for distension and offering a bedpan to your patient, or straight cathing that. Okay. Postpartum. What are we going to monitor for in patients with an epidural? The return of sensation and motor control in the client's legs after delivery, but prior to standing. It means that after your patient had that baby, you stop the epidural. You don't just walk away and say, oh, when you have to go to the bathroom, you could just get up and go to the bathroom. No, your patient cannot come out of bed without you being there the first time. You need to make sure that their legs are strong enough. You need to make sure that, that they can stand up, that they can feel their legs before they get up. So the first time they come out of bed, you as the nurse need to be there. Okay, you want to assist them to the standing and walking after the first time if they have an epidural. Please note, when they give an epidural, there's like a catheter that's left in place. Many of them are put on a pump. Others, the anesthesiologist can just come back in every so often and just, give them medication whenever. But most hospitals just put the patient on a pump. Pudendal block. This is a regional block. It is done transvaginally, all right, into the space in front of the pudendal nerve. This type of block has no maternal or fetal effect. So there's nothing making them groggy or nothing like that. It just literally blocks the pain in the vaginal area. And it is fantastic to be used for to minimize pain in the perineum, the vulva, and the rectal areas during labor, during the delivery process. So it usually happens, you know, this is something that you do in the second stage of labor, 10 to 20 minutes before the actual delivery of the baby. So you don't do it when they're 6 centimeters, 5 centimeters. No, you do it when they're already 10 centimeters and they're like ready to push. This is when you would do this pudendal block. Okay, please note it may lead to broad ligament hematoma, and it might compromise the maternal bearing down reflex. So when women are pushing, you know how you hear in the movies, I want to push, I want to push. They literally want to push. It's almost like this urge to have a bowel movement and they can't control it. They just have to push. However, when you have a pudendal block, it might hinder that. Okay, it might compromise that. Postpartum, make sure that we're assessing the perineum and the vulvar area for hematomas that can occur as a result of this pudendal block. Nutritional needs. All right, let's see. Nutritional needs, very important. We know diet is important whether you're pregnant or not. And when I say diet, I don't mean not eating. I mean what you eat, right? Please note the caloric intake, the first trimester, so up to 12 weeks, how many more calories should you be consuming? 0, nothing, okay? In the second trimester, you can increase your daily caloric intake by 340 calories. What has 340 calories? Nothing. Like, you could eat a quick snack. You know, I buy these almond butter bars, and the almond butter bars are like 280 calories, and it's one little bar. So this mentality of, oh, I'm eating for 2, and then instead of having 1 plate, they have 2. That's a no-no, okay? This, I know in Hispanics, that's like a big one, all right? Oh, I'm eating for 2, and then they stuff their faces. They gain a ridiculous amount of weight. They develop gestational diabetes, and then they wonder why they end up in a C-section. Which, by the way, one of the reasons why women end up in a C-section is because they gain so much weight during pregnancy. But I digress. Anyway, third trimester, you can increase your caloric intake by 450 calories a day. Because your baby's bigger and now needs a little bit more calories. You need to consume a little bit more because your body's burning a little bit more to be able to sustain this other baby. Postpartum, if you are breastfeeding, and girls, those of you who don't have babies yet, if you plan on having babies, you can up your caloric intake 400 to 500 calories a day. Why? Because when you're breastfeeding, exclusively breastfeeding, you burn about 500 calories a day. I don't know about you, but to burn 500 calories at the gym, you have to work out for like 2 hours, all right? So it's pretty good, but this is like breastfeeding only. A lot of women do this. The fabulous thing about breastfeeding is that it helps women stabilize their glucose levels, all right? So those women who have gestational diabetes, they are highly encouraged to breastfeed because of this. In addition to that, it helps the uterus to involute. Remember, anytime you breastfeed, oxytocin is released. Oxytocin is a uterotonic, and it helps with uterine involution. Special diets. Oh, by the way, the only thing I was gonna say is that it is the general rule that clients should gain 1 to 2 kilos or 2.2 to 4.4 pounds during the first trimester. After that, they should gain about 1 pound per week for the last 2 trimesters, all right? So they can gain anywhere from 28 to 40 pounds. Overweight clients should only gain 15 to 25 pounds. So if you are going into a pregnancy and you're already overweight, you know these calories that I gave you, you're not entitled to them, okay? I'm sorry. You have to just keep your regular diet and then hopefully not gain more than 25 pounds during your pregnancy. Special diets, all right, with diabetes. Very important that we decrease the, what do you call it? Carbohydrates, all right, and that they monitor it. If your patient has gestational diabetes, remember we control their diabetes either with diet alone or with a sliding scale of insulin, an insulin sliding scale. We want to make sure that the clients are not eating high levels of sugar or starches, that they eat lots of fruits and vegetables to try to manage, and protein, of course, to try to manage the diabetes. And if you see this little picture that I have here, everything on there is protein. The snack, they're fruits, which have carbohydrates, but it's not the same as having bread, rice, or beans. And you see only one snack consists of a true carbohydrate, like a starch, which is this bread. With cholelithiasis, what are we gonna do with cholelithiasis? All right. Low-fat diet. They have to have a low-fat diet, all right, patients with cholelithiasis. With hyperemesis gravidarum, same thing that I told you before with people who are vomiting a lot. They should have multiple small meals, and they should have multiple small meals, not drink with their meals. They should be drinking in between. With hyperemesis, remember, this is patients who have abnormally high levels of HCG, patients who have a history of H. pylori, a lot of emotional stress, and then just the hormonal levels are basically the culprits of this hyperemesis gravidarum. With PKU diet, it is important that we understand, sorry, it's an alarm that I have and I can't forget, so I can't turn it off. It's a genetic disease where they have high levels of, where they're not able, they don't have the enzyme to break down phenylalanine, and therefore they have to decrease the intake of phenylalanine. All right, what has phenylalanine or a lot or high levels? Foods that are high in protein, like fish, poultry, meat, eggs, nuts, dairy products. Anything that is high in protein, when you're on a PKU diet, you have to eliminate. So you're basically eating a lot of fruits and vegetables for the most part. Aspartame, diet sugar, you have to completely avoid it because it contains phenylalanine, all right? So it should definitely be avoided in clients who are on a PKU diet. Please note, phenylalanine levels are gonna be monitored during pregnancy, and the diet should start not when you find out you're pregnant, but 3 months before. If you're trying to get pregnant, you need to know that you have to go on a PKU diet, okay? Before and during your entire pregnancy. So again, going back to the diabetes, monitor the amounts of carbohydrates in the diet, keep the glucose within target ranges, limit the number of sweets and desserts, and then we want to always refer these patients to a registered dietitian, okay? Supplements, very important. Folic acid is a big one, okay? Folic acid is crucial for neurological development, okay? And it helps in the prevention of neural tubal defects. It can be found in foods like leafy vegetables, dried peas, and beans. But either way, most prenatal vitamins have folic acid, and sometimes physicians will even give you, have you take your prenatals plus a little pill with folic acid. Iron supplementation. Please note, iron is best absorbed between meals. So don't give it with your breakfast, lunch, or dinner. It has to be in between meals and with a source of vitamin C. So you want to take your iron pill with a cup of orange juice, all right? Milk and caffeine actually interfere with the absorption of iron supplements. So you cannot or you should not drink your iron supplementation with milk or coffee. Ideally, you want to do it with a lemonade, an orange juice, and in between meals. Because if you have it with the rest of your meals, you're not going to get the same absorption rate. Foods that are high in iron, and I know if you're Hispanic, you've heard this: hígado, liver. Oh, you're anemic. Here, let me give you liver. The beans, the lentils, fortified cereals, all of these things are high in iron. Please note that when you're increasing your iron intake, you might need a stool softener because it can cause constipation due to the iron. Calcium, also very important for them to consume. The daily recommendation is for pregnant and non-pregnant patients, 1,000 milligrams per day. All right, you do have foods that are rich in calcium, okay? Which are what? And you guys need to know this, all right? Good sources of calcium are milk, calcium fortified soy milk, fortified orange juice, Nuts are rich in calcium, legumes, and dark green leafy vegetables. All right. These are high in calcium. So if I ask you which one of these, well, this picture is not really good because it doesn't have a lot of calcium rich foods in the picture. But I guess whatever has green vegetables on it would be good. Dark green leafy vegetables, nuts, legumes, orange juice, and then dairy products that have been fortified, soy products that have been fortified, and milk. They all have calcium. Make sure that you encourage your patients to drink 8 to 10 glasses of fluid per day, preferably water and juices, meaning no carbonated drinks, no juice, no caffeinated drinks. Limit your caffeine intake with your pregnancy. Let's see, fetal well-being. All right, this is the fun part that everybody loves. So I'm going to kind of go around everything, not go in the order. So let's talk about ultrasounds. All right, we know what an ultrasound is. We know that there's different types. You have an abdominal, a transvaginal, and a Doppler ultrasound. All right, we need to know that if you are doing an ultrasound on somebody who is less than 20 weeks gestation, the bladder has to be full so that the examiner, whoever's doing the tech that's doing the ultrasound test, can better visualize the baby, as when the bladder is full, it pushes the gravid uterus from outside of it displaces it from the pelvic cavity, and so it's easier to visualize. So if they're less than 20 weeks gestation, we want to make sure that they have a full bladder. If they're more than 20 weeks gestation, that's really irrelevant. You just want to explain the exam. If your patient is lying flat on their back, you want to make sure that you put something underneath their hip so that you can tilt the pelvis and decrease the compression of the inferior vena cava. With a transvaginal ultrasound, all right, it's an invasive procedure. You want to make sure it's covered with a sterile with a condom like a condom over the probe. And we want to make sure, we want you to know it does not require a full bladder because you're going from underneath, all right? So you do not have to have a full bladder. We usually do a transvaginal if it's really, really early on in the pregnancy, or patients who are like really obese that, you know, they have a lot of adipose tissue and it makes it really hard to visualize the baby via an abdominal ultrasound. Transvaginal, we also utilize it to detect an ectopic pregnancy and sometimes identify abnormalities. Also used to establish gestational age, okay? In the third trimester, a transvaginal can be done in conjunction with an abdominal ultrasound to assess for preterm labor. Okay, remember when we're measuring the cervix? For preterm labor, 20 millimeters or less, it means they're probably going to go into preterm labor. More than 30 millimeters, we're not so concerned. Biophysical profile, it's basically like APGAR scoring, but while the baby is still in utero, no big deal. Non-stress test, and this is, notice how I have ultrasound, non-stress test, and chorionic villus sampling highlighted or bolded, better yet. So a non-stress test, I have a little picture over here. Are you guys able to see my cursor? Yeah, okay. So this is what an NST looks like, all right? Remember, with an NST, we are looking at this top part. These little markings are fetal movements, okay? How do we know that there's fetal movement? Why are those markings there? Because you gave mom a little clicker and you laid her down, you put her on her monitor, and you're checking for contractions and you're checking for fetal heart rate, and you gave her this clicker and you tell her, okay, mommy, anytime you feel the baby move, please click, all right? When mom does that clicker in the strip, you should see a reaction, an acceleration. This is an acceleration. In this case, this is the baseline. You see this? This is the baseline. All of these are accelerations. What is an acceleration? It means that the heart rate goes above the baseline. If you are between, okay, let me go back some. For an NST, who can get an NST? Anybody who is 28 weeks gestation or above. If some doctor sends you a patient and they're 21 weeks and they say, oh, do an NST on this patient, don't tell them, yes, doctor, because they're going to say, what a fool. They don't know what they're doing, okay? We do not do NSTs on anybody who's less than 28 weeks gestation. It's not a valid test, okay? So if you are between 28 weeks gestation and 32 weeks gestation, what do we categorize as an acceleration? 10 by 10 accelerations. What does 10 by 10 mean? It means that it goes above the baseline for 10 beats. So if your baseline is 120, it has to go up at least to 130. And it must stay away from the baseline for at least 10 seconds. That's what 10 by 10 means. That is if and only if you are 28 to 32 weeks and you would want to see in a 20-minute period, at least 2 accelerations, 2 10 by 10 accelerations between 28 to 32 weeks. If you are 32 weeks and above, 10 by 10 doesn't cut it anymore, all right? It has to be a 15 by 15. 15 by 15. So if your baseline was 120, and now for it to count as an acceleration, it has to go up at least to 135 and stay away from the baseline for at least 15 seconds, all right? That is an acceleration after 32 weeks gestation. So when we're doing an NST, we want to look at a 20-minute strip. And in that 20-minute strip, we want to be able to see at least 2 accelerations from 28 to 32 weeks of 10 by 10, above 32 weeks, 15 by 15. If you have that, what do you have? What are your results? A reactive NST. Okay, so that means that is good. Your baby is reactive, everything is golden. If you don't have that, what are we gonna do? We are going to do interventions. What interventions are we gonna do? You can reposition mom, you can give her some ice to chew, you can perform vibroacoustic stimulation, okay? Etc. And then you give her up to an additional 20 minutes. If you look at your ATI book, if you guys have it, you guys can go back to it. It's on page 33. It gives you an example of a reactive non-stress test. If you notice, that particular patient has 0 contractions and she has 4 accelerations. I don't know how pregnant this patient is. I don't think the book says it, but it doesn't matter. The accelerations are way bigger than 15 by 15. So it is an obvious reactive non-stress test. All right, so make sure that you go back and you do that. When do we do a non-stress test? Patients who tell you, they come into the hospital and they say, oh, I haven't felt my baby move in, whatever, since yesterday. You want to make sure you put them on the monitor and that you performed an NST. A contraction stress test, in essence, is the same thing as an NST. The difference is that you are inducing contractions. And if you are inducing contractions, guess what? There's risk associated with that, which means you need to make sure that your patient signs a consent. All right. The key with a contraction stress test, but actually before I continue with that, if we have an NST that is non-reactive, it means you didn't have any acceleration. So it'll just look like variability that never changes. Okay. That would be a non-reactive stress test. Keep that in mind. With a contraction stress test, you are inducing contractions. You need a consent. And what we're looking for is to see if the baby is able to tolerate labor. When mom goes into labor and she starts having contractions, how is this baby going to react? So let's say you were able to induce 4 contractions. And with every one of those, or with 3 of those contractions, every time the contraction came, the baby had a late deceleration. You guys remember what a late deceleration is? A late deceleration means that the nadir of the deceleration occurs after the peak of the contraction. It means that the deceleration starts after the start of the contraction. So the contraction starts, and then when it's like about to peak, the deceleration stops. So it's kind of late to the party. That is what a late deceleration is. and it is not a good deceleration. No decelerations are good except for early. So anyway, when you're doing a contraction stress test, you induce these contractions, and let's say that for 3 out of the 4 contractions that you induced, you had a late deceleration, the reaction of the baby was a late deceleration, that would be a positive contraction stress test. And in this case, the word positive is actually a bad thing, okay? Because it means that for 50% or more of the contractions that you managed to induce, the baby had a negative response. That would make it a positive contraction stress test. Let's say you induce the same 4 contractions and the baby didn't even realize it. No decelerations whatsoever, kept on going about this business, you know, having variability and maybe even accelerations. You're like, perfect, this is a negative contraction stress test, which means the baby tested negative for their inability to tolerate labor, okay? It means that baby will have no problem during the labor process, or at least at that moment, if mom went into labor, the baby's not gonna have an issue. Chorionic villus sampling. What are we talking about when we talk about chorionic villus sampling? Remember, this is one of the tests that we do on patients that are high risk, patients who have a history of genetic disorders, patients who are advanced maternal age, patients that we suspect there could be something wrong with the baby, high risk pregnancies. This can be done as early as 10 weeks gestation. 10 weeks gestation, which is really, really early. But I want you guys to, hold on, let me see. With the chorionic villus sampling, it is important to know, number one, that there are risk factors. There is a 7% chance of fetal loss due to bleeding, infection, or ruptured membranes. So number one, you need to make sure that the woman is aware of all of these, you know, risk factors, and that you provide support to your client, okay? You want to teach them breathing techniques and relaxation techniques while they do this. This is done with an ultrasound. It's guided, the needle is guided with an ultrasound, all right? Now, very important, post-procedure, that we educate the mom, all right, on what to report. If she develops or starts having abdominal pain or cramping, leaking fluid, bleeding, has a fever or chills, they need to notify the provider immediately, okay? Immediately after the procedure, you must monitor the baby at least twice in a 30-minute period. Usually in the hospitals, they leave them on the monitor. You know, they just put them on the monitor and they do continuous monitoring. But at a minimum, the fetal heart rate has to be auscultated or monitored twice in a 30-minute period. Now, if your patient is Rh negative, make sure that you are administering RhoGAM post the procedure, because remember, you are piercing through a lot of things. So there could be, you know, the blood cross-contamination. So in order to prevent isoimmunization, you want to make sure that you administer RhoGAM for patients who are Rh negative, okay? Amniocentesis is very similar. It's just done after 15 weeks versus 10 weeks. It is done anywhere from 15 to 20 weeks gestation. There are also risk factors associated with this. Same thing, women should not be lifting anything heavy or doing any like heavy activity for at least 24 hours. And they should report the same signs and symptoms that they can experience with chorionic villus sampling. The quad marker and maternal alpha fetal protein markers, these are blood tests. So there are no risks really. And you guys can just go back, and I urge you to just look back at these, okay? Accelerations, we know what those are. Variable decelerations, they look like V's or W's, and they're indicative of cord compression. Early decelerations are the only decelerations that are allowed or that are not alarming. Or concerning, better yet, not alarming, because if you're having a lot of late decelerations, it could be your baby's about to come, your patient's about to deliver, so you have to be ready. Late decelerations, we just talked about. Prolonged decelerations, I'm gonna show you. This is what a prolonged deceleration looks like, okay? You see it? It lasts between more than 2 minutes, but no more than 10 minutes, okay? So a deceleration, a prolonged deceleration can be more than 2 minutes long, like 2 minutes and a second, 3 minutes, 4 minutes, up to 10 minutes. This is what a prolonged deceleration looks like, okay? So a decel, it means it drops from the baseline more than 15 beats per minute. So if your baseline was 120, it'll drop at least into 105, okay? That is a 15 beat per minute drop. And then it'll remain there anywhere from 2 to 10 minutes. I just want you to be able to recognize a prolonged deceleration. This can happen as a result of a cord prolapse, or just the baby maybe is just not doing well, if they have some congenital condition, or if let's say mom was tachysystolic, contraction, eventually the baby gets stressed out and it'll just like drop, okay? I was talking about a non-stress test. This is an example of a non-reactive. So the one that we saw on the previous page was a reactive NST. You saw the accelerations. This is what a non-reactive stress looks like. As you can see, it has some variability, but there's absolutely no accelerations. This is fetal movement, fetal movement, fetal movement, fetal movement. And every time the baby moved, there was no acceleration. And that is what a non-reactive stress looks like. We're going to talk about labor complications. And I just briefly talked about a cord prolapse. And we've talked about this in lecture before. I know that it's in the lectures. But an umbilical cord prolapse can happen when the doctor goes in to perform an artificial rupture of membranes, okay? I'm sorry. Okay, when a doctor goes in to do an artificial rupture of membranes, if the baby was not well engaged, all right? What does well engaged means? That the head is right there and it's like basically entering the pelvis, the birth canal, and there's no way that the cord can go before it. If the head, the baby's station is ballotable, okay, and the membranes are ruptured and the cord just happens to come in front of the presenting part, that is what we call an umbilical cord prolapse. What are we going to do? This is an obstetrical emergency. This woman can no longer deliver vaginally. So you have to position the mom, you can put her on Trendelenburg. So what we're trying to do is to elevate the presenting part. What does elevate the presenting part mean? You want to move it away from the exit because it is going to compress the cord. And if it compresses the cord, what are we doing? Strangling our baby, right? So we want to elevate the presenting part. If it happens to be outside of the vagina, you want to, put her in Trendelenburg, put her on, knees to chest position so that you're elevating the bottom. And you want to cover it. If it's coming out, you want to cover it with a sterile gauze that has been soaked in sterile saline. So you would position her upward, whether it's in Trendelenburg, chest, knees to chest, and cover the cord with a gauze that has been soaked with sterile saline, sterile gauze, sterile saline, because we don't want the cord to dry. If it is still inside the vagina, but it is, again, before the presenting part, the nurse would stick her gloved fingers inside the vagina and push the presenting part away from the cord and keep the cord there between her fingers. You find it, it's yours. And you're not coming out of there until the baby comes out via C-section. You have to call for help, of course. Let me see. You want to administer O2, 8 to 10 liters via face mask. Make sure that you have IV access. Apply a warm, sterile, saline soaked towel to the visible cord to prevent drying and to maintain blood flow. Variable decelerations might be present. Remember, variables are indicative of cord compression. Remember that veal chop. Variables are indicative of cord compression. So, and may indicate fetal asphyxia and hypoxia if the cord has been compressed. So whenever we do a rupture, whenever a patient ruptures their membranes, you want to make sure that you watch that monitor because an umbilical cord prolapse can occur. Okay, meconium stained fluid. All right, this is when your patient ruptures and the amniotic fluid that comes out of there is not whitish, clearish. It looks greenish. All right, it is meconium stained. It means the baby has had a bowel movement in utero, and it is staining the fluid. Okay, and there's an increased chance after 38 weeks gestation due to the fetal maturity, of course. If the baby experiences something that causes them to become hypoxic or stressed out, like you have a vagal nerve response and they pass meconium. So having a meconium stained fluid could be indicative of that. It could be that they, what do you call it, had an episode, an event or something that stressed them out enough to vasovagal. All right. Fetal distress. Fetal distress is present when you have a fetal heart rate that is outside of those parameters of 110 to 160. Either the baby's tachycardic or the baby is bradycardic. All right. Or we have no variability, absent variability or minimal variability. It's indicative of fetal distress. All right. Late decelerations are associated with additional mesificization of fetal distress are late decelerations that are associated with absent or minimal variability, recurrent variables, and prolonged decelerations. That is basically a category 3, all right? Your baby is in a lot of distress and you need to be doing something quickly. This can happen if the baby already has fetal anomalies, if there are uterine anomalies or complications during birth. If your patient has a ruptured uterus, or a placental abruption, you'll see late decelerations. You'll see a baby who develops distress as a result. What are we going to do? You want to position your patient on the left to increase placental perfusion. You want to administer oxygen via face mask. If they're on oxytocin, you absolutely must discontinue it because then you're stressing out a baby that is already stressed out, all right? Increase the IV fluid rate to treat hypotension if it's indicated. And then you must prepare when you have this fetal distress, which is a category 3, you are definitely preparing for a stat cesarean section. Dystocia, I'm not going to get into too much dystocia because I know we just uploaded, or I don't know if Dr. Perez has done it yet. I'm sure she's going to do it soon. The lecture for this past week where we talked about dystocia, and I go into detail with that. So make sure that you listen to your lecture for this week. Precipitous labor means from the onset of labor to delivery is less than 3 hours. The baby is at risk for trauma because this happened too quickly. And mom is also at risk for chances of having a laceration, perineal laceration, also because of the speed at which, the labor progressed. A uterine rupture usually happens in patients who do not have an intact uterus. What does that mean? A patient with a history of cesarean section. If they have a C-section, all of a sudden they start contracting, they can have a uterine rupture. Most of the times it happens if they administer oxytocin, which is why we cannot induce or augment the labor of a patient who is attempting a VBAC, vaginal delivery after cesarean section. I also talk about it in this week's lecture, so I'm not going to go into it a lot. All right. Anaphylactic syndrome of pregnancy, also known as the amniotic fluid embolism, okay? Amniotic fluid embolism can occur anytime after the membranes rupture. It could be while you're still pregnant, and it could be up to 24 hours after the delivery. I also talk about it in the lecture, so I'm not gonna get too into it. Please know, we don't fully understand it. We just know amniotic fluid goes into the maternal bloodstream, and it can cause a respiratory arrest. It can cause, a whole bunch of things. I have, and I think I talk about it in the lecture, a friend who had a patient, she went in there, was talking to the patient perfectly fine, walks out of the room, sits at the nurse's station, this was at Jackson North, which was maybe 30 steps from the patient's door. The minute she sat down, immediately the husband came out and said, there's something wrong with my wife. She goes back in there, completely lost consciousness. She's just like this. They worked her, they were able to bring her back. They actually had to deliver the baby right there, no anesthesia, no nothing, but she was dead for all, intents and purposes. They took the baby out. The baby was fine. They worked her. They were able to bring her back. They took her to the ICU. She coded multiple times and eventually she passed. Afterwards, the autopsy confirmed that they said the only cause for that was anaphylactic syndrome of pregnancy or an amniotic fluid embolism. Okay, so this does happen, and I'm not going to get too into it because, again, I talk about it in this week's lecture. Make sure that you listen to that. So, guys, again, I cannot stress enough how important it is for you to, what do you call it? Review your questions, review your rationales, okay? And